So, I want you to imagine health not as a repair shop for broken bodies, but as a towering, magnificent skyscraper.
Okay, I like that image.
Right. And when you picture a hospital or a local clinic or an intensive care unit, what you are really looking at are the window washers, the maintenance crews.
The people doing the immediate urgent work.
Exactly. They are suspended way up there on the 50th floor, working tirelessly in the wind. They're patching up cracks in the glass, fixing the plumbing, just dealing with emergencies as they arise. And their work is absolutely critical, right? I mean, they save lives every single day.
They absolutely.
But public health.
Mhm.
Public health is the structural engineering of the entire building. It's the foundation poured deep into the earth.
Right, it's the invisible stuff.
Yeah, it's the city zoning laws dictating where that building can even be constructed in the first place. It's the soil quality, the wind resistance, the seismic shock absorbers built into the very skeleton of the tower.
Because if you want to understand why the building sways in the wind, or why it stands firm when the ground shakes, you can't just look at the 50th floor.
We have to go deep underground.
And that is precisely the shift in perspective we are taking today. We are moving far beyond just biology. We're going to explore the layered and, as you said, often invisible architecture of why populations either thrive or suffer.
Which is really the core of our mission in this deep dive. We are unpacking Chapter 2.1 of the Oxford Textbook of Global Public Health. And just to be clear, this isn't just about reading a textbook to you.
No, definitely not.
This is a conceptual toolkit. Whether you are a medical student, a junior doctor, a public health trainee, or a practicing clinician, we want to help you build clear, robust frameworks for understanding the vast forces at play before a patient ever even walks into your exam room.
Right, because we are going to look at the classical models of health determinants first, and then we'll venture into the incredibly complex interacting systems that truly dictate health outcomes.
A really dynamic stuff.
Exactly. We're talking about dynamism, multi-scale interactions, cross-boundary risks, and abrupt state changes.
Okay, let's unpack this. We should probably start with the foundation. Historically, when we talk about what determines health, the classical framework neatens everything up into four main buckets.
Like the traditional categories.
Yeah, you have your behavioral factors, the impacts of the natural environment, genetic determinants, and social determinants. And I mean, it sounds very organized, right? You have your neat little categories.
It does sound neat, but the reality is that those overarching categories can actually mask the profound interwoven complexity of how these drivers interact.
They aren't just isolated silos.
They absolutely are not. What's fascinating here is how these determinants have acted and interacted in incredibly complex ways throughout human history.
Can you give an example of that?
Sure. If you want a really visceral example of how these determinants collide, look at the European conquest of the Americas in the 16th century.
Okay, the historical anchor.
Yeah. When we learn about the massive decimation of Native American populations, the biological determinant is usually front and center, right? We talk about the spread of infectious diseases like smallpox, measles, and plague.
Which is the standard narrative. Europeans had developed moderate resistance over generations, but they met an immunologically naive population in the Americas, and biology just kind of took its course.
But it wasn't just biology at work. That is a massive oversimplification.
Right, because if it were just biology, the survival rates would have been different. What we are actually looking at is a cascading system failure.
Exactly.
It was subjugation, which is a massive social determinant. You have entire societies being dismantled. Then you have land confiscation, which leads directly to food insecurity.
So now you have an environmental and a social determinant colliding.
Right, you have a population that is being socially fractured, environmentally displaced, starved of calories, and then hit with novel pathogens.
And from a clinical perspective, we know exactly what starvation does to the human immune system. Malnutrition drastically reduces cell-mediated immunity.
It just shuts it down.
Yeah, so the pathogen wasn't just meeting an immunologically naive host, it was meeting an immunologically suppressed host, living under chronic, severe psychological and physical stress. You cannot separate the biological pathogen from the social and environmental violence. They amplified each other exponentially.
And this brings us to how specific cultural and economic practices weave into these determinants. Because culture isn't just, art and music and food. It is a direct biological determinant.
Sometimes it's incredibly health-promoting, and sometimes it's deeply health-damaging.
For instance, the simple protective practice of breastfeeding. This is a cultural norm in many societies that acts as an invisible shield. It specifically reduces the risk of diarrheal infections and death among infants by passing maternal antibodies and seeding a healthy gut microbiome.
But then you have cultural practices that introduce severe hazards. Like take the historical, and sometimes still ongoing, practice in certain regions of wiping an infant's newly cut umbilical cord with dung.
Wow. Yeah.
Culturally, it might be viewed as a restorative or a protective act. But biologically, it introduces Clostridium tetani spores directly into necrotic tissue. It violently raises the risk of neonatal tetanus, which has an incredibly high mortality rate.
Or consider the traditional use of lead-containing pigments in cosmetics and traditional medicines. Culturally, it's an aesthetic or healing practice. Biologically, it leads to chronic lead toxicity.
Right, presenting as anemia, abdominal pain, and irreversible neurocognitive damage in children. Culture dictates the exposure.
Even how we view tobacco use and tobacco restriction is cultural. If you want to implement tobacco control, you can't just explain the biology of lung cancer to a patient.
No, that really works on its own.
You have to understand the cultural context of smoking in their specific community to find the actual leverage points for changing behavior.
And if we connect this to the bigger picture of economic determinants, we see another layer of immense complexity. Economics is a massive driver of health, but we really need to dispel the myth that it's a simple linear equation where more money always equals better health.
There's a catch.
There's a fascinating paradox that defined the 20th century. As countries experienced increasing economic prosperity, they achieved better housing, reduced crowding, improved water and food quality, and reduced dangerous working conditions.
Oh, wait, but surely that's a net positive, right? I mean, the downstream effect of that was a massive reduction in infectious diseases like cholera, tuberculosis, and occupational respiratory diseases.
Absolutely.
It dramatically increased human lifespan. If the trade-off for not dying of an infectious disease at age 30 is that you have to deal with a chronic condition at age 70, isn't that just a natural consequence of the victory of living longer?
That is the common assumption, but it misses a critical nuance. Yes, living longer exposes you to diseases of aging. But what prosperity brought wasn't just longer life. It brought an abundance of relatively inexpensive, highly processed foods loaded with sugar, saturated fat, and salt.
Ah, the dietary shift.
And this shift engineered entirely new population health risks that are presenting prematurely. We are not just talking about 80-year-olds developing diabetes. We are talking about the modern epidemics of obesity, type 2 diabetes, and cardiovascular diseases striking people in their 30s and 40s.
So it's an engineered metabolic crisis, not just a byproduct of aging.
Precisely. We see this across wealthier nations, but we also see it rapidly emerging in the rising middle classes of low and middle income countries.
It's like an evolutionary mismatch.
That's a great way to put it. Human biology evolved for scarcity, and suddenly, economic development drops it into a highly obesogenic environment of cheap, hypercaloric food and sedentary labor. So economic development solved one set of infectious, poverty-driven diseases, but it manufactured a new set of chronic, consumption-driven diseases.
It's the double-edged sword of development. And at the exact opposite end of that economic spectrum, poverty is still driving unhealthy housing, deficient infrastructure, malnutrition, and dangerous occupational exposures.
Right.
But as economies improve, they get the opportunity to invest in public health interventions. We are talking about the large-scale invisible things, the provision and disinfection of municipal water supplies, fortifying everyday staples like flour with folic acid to prevent neural tube defects,
or reducing unventilated cooking with solid fuels inside the home. When you replace a biomass stove with clean energy, you drastically cut the risk of severe chronic obstructive pulmonary disease and acute lower respiratory infections in women and children.
or enacting vehicle and building safety codes. And this brings us to a crucial conceptual framework for anyone working in health: the fundamental difference between a hazard and a risk, and how public health intervention bridges the two.
Let's use a powerful real-world example to illustrate this difference. In 2010, a magnitude 7.0 earthquake struck Haiti. The result was a catastrophic loss of life. Estimates are over 200,000 deaths.
It was devastating.
It was. But that very same year, a much larger earthquake, an 8.8 magnitude, struck Chile. Yet in Chile, the loss of life was roughly 700 people.
This is the perfect illustration of differentiation. The hazard, the raw geological seismic activity of the Earth, was actually worse in terms of energy release in Chile.
Much worse.
Because a hazard is just a potential source of harm. But the risk, the actual vulnerability of the population to structural collapse, crush injuries, and death was vastly different. Why? Because of upstream engineering.
Exactly. The intervention wasn't a better trauma bay or more surgeons.
No, the public health intervention here was the establishment and rigorous enforcement of building codes. It was requiring steel rebar in concrete, mandating specific curing times, and having uncorrupted zoning and inspection processes.
And the hazard was a geological event. The risk was a failure of infrastructure policy.
So, treating a crush injury in a hospital is the 50th floor window washer. The building code that prevents the ceiling from collapsing in the first place is the underground structural engineering.
That is public health.
But as we move forward, these classical categories, social, environmental, genetic, they are no longer enough. The catalog of determinants is expanding because the world is changing rapidly.
We have to look at globalization, climate change, urbanization.
We are dealing with complex socio-environmental phenomena, and to really grasp them, we have to look at 4 complicating features of health determinants.
Let's delve into the first complicating feature, which is dynamism. This is about time, lags, and the life course. Health determinants do not operate on a simple, instantaneous action-reaction timeline. In clinical medicine, if you give a beta blocker, you see the heart rate drop. It's immediate.
But in population health, expressing the relationship between an exposure and a disease as a simple relative risk actually does very little to convey the complex temporal realities.
Because an abrupt change in exposure doesn't always equal an immediate disease response. There are massive time lags.
Think about indoor air pollution or cumulative cancer risks. If a factory worker is exposed to asbestos and you stop that exposure today, the mesothelioma might still manifest 30 or 40 years from now.
Because of the cumulative cellular damage already done.
Exactly. The exposure is gone, but the biological clock is still ticking.
And this leads us to the life course perspective. We have to consider how exposures are experienced over a series of life stages. Factors that influence growth and development very early in life can have dramatic, irreversible consequences for health in adulthood.
Here's where it gets really interesting. Let's talk about fetal programming. Insults during fetal, infant, and childhood development. Things like maternal undernutrition, severe childhood infections, or early environmental toxic exposures, they do not just cause childhood illness.
No, they don't.
They actually dictate a person's susceptibility to multiple health outcomes decades later.
This is deeply rooted in what is often called the Barker hypothesis, or the thrifty phenotype.
Can you explain how that works physiologically?
Sure. If a mother is severely undernourished during pregnancy, the developing fetus receives signals that it is going to be born into a world of severe caloric scarcity. So it adapts.
It prepares for famine.
Exactly. It undergoes epigenetic modifications to downregulate insulin receptors and conserve every single calorie it can. It prioritizes brain growth over the development of organs like the pancreas or kidneys.
So the fetus is doing exactly what it is supposed to do to survive a famine.
It's a brilliant survival mechanism. But then that child is born, and perhaps the economy is shifted. They're not born into a famine. They are born into an obesogenic environment with cheap, calorie-dense foods.
So their metabolism is entirely mismatched to their environment.
Exactly. This inadequate early development, which is tragically prevalent in many low- and middle-income countries, leads directly to massive spikes in non-communicable chronic diseases like hypertension and type 2 diabetes later in life. The die is cast very early on.
And this dynamism creates a massive headache for public health policy and research methodology. I mean, how do you study an exposure that happens in utero and a disease that happens 50 years later?
It's incredibly difficult.
It brings up something called the discount rate dilemma. Think of the discount rate like a public health mortgage. Because health effects are spread out over time, policymakers have to apply analytical approaches to weigh the relative importance of current conditions versus future conditions.
This raises an important question for policymakers, and it is a source of immense friction. If a minister of health spends $10 million today on a massive anti-smoking campaign, the real financial and health payout, the reduction in expensive lung cancer and COPD treatments, won't happen for 30 years.
But politicians run on 2 to 4 year election cycles.
Right. How do you convince a current administration to spend their limited budget on a reward that their successor's successor will get the credit for?
You cannot solve a 50-year biological problem with a 2-year political funding cycle.
Precisely. When there is little consensus on which discount rates to use, it is incredibly difficult to strike a balance. This poses a special challenge for assessing the health impacts of exposures that extend far into the future, like global climate change or interventions phased in over decades.
Dynamism forces the public health community to explicitly balance the interests of current generations against the interests of future generations. It demands long time horizons for policy analysis and a lasting commitment to longitudinal studies.
Which brings us to the second complicating feature, multi-scale. Health threats span an enormous spectrum, from the microscopic level of molecules all the way up to the planetary level of the climate.
And here we encounter a critical trap, which I think is a profound insight for any practicing clinician listening to this. Professionals typically operate at the scale of their training.
It's human nature, but it is a systemic vulnerability. Physicians and nurses are trained to work at the personal, microscopic, or molecular scale. They look at the patient in front of them.
Hospital administrators work at a derivative, institutional scale. They look at bed capacity and supply chains.
Ministers of health look at national governance and healthcare budgets. And at the highest level, elected officials develop military, industrial, or agricultural policies that have sweeping global consequences for health, often with very little awareness of those impacts.
I can hear a clinician listening to this and thinking, wait, I'm a doctor. I have 15 minutes with a patient. I need to focus on the person in front of me. I can't be worrying about global agricultural policy when I'm trying to manage someone's blood pressure.
And that is a completely valid clinical reality. But if we only operate at the scale of our training, we will never actually solve the root of the problem. We will just be endlessly bailing water out of a sinking boat without ever patching the hole.
Let's look at malaria as a brilliant example of systems thinking across scales. If you want to truly understand and stop the transmission of Plasmodium parasites, you have to look at multiple scales simultaneously.
Right. Scale 1 is the micro level. This is where the clinician lives. It's host immunology, the nutritional status of the patient, the microscopic biology of the parasite, and choosing the right artemisinin-based combination therapy.
But that is not enough to stop the disease. So we zoom out to scale 2, the meso level.
This is the realm of the vector biologist and the local public health officer. They're looking at the local population dynamics of the Anopheles mosquito. They're looking at the community housing infrastructure. Are there screens on the windows? Is there stagnant water in the drainage ditches? What is the availability and usage rate of insecticide-treated bed nets?
And then you have to zoom out again to scale 3, the macro level. This is the climatologist's domain. Global climate change is actively altering temperature isotherms.
It is warming higher altitudes, which means the mosquito vector is expanding its geographic reach, bringing the parasite up mountainsides in Africa and South America into entirely new, immunologically naive populations.
The takeaway for you listening is this. You cannot solve a multi-scale problem if you only consult the microbiologist and completely ignore the climatologist.
The health practitioner has to understand the range of parameters driving the threat. Even if your daily job is prescribing the antimalarial, you have to be able to articulate the need to abate large-scale upstream determinants.
You have to understand that heat island effects, or agricultural irrigation practices, are driving the narrow downstream clinical manifestations you are seeing in your ward.
That requires serious cross-domain awareness. It requires stepping outside the traditional, comfortable boundaries of medical training.
Which leads us perfectly into the third complicating feature, cross-boundary risks. Simply put, health determinants do not carry passports. They do not care about international borders or customs checkpoints.
We see this most clearly with environmental pollutants. Dust from desertification sources in Asia traverses the Pacific Ocean and reaches the surface of the United States in a matter of days.
Carrying particulate matter that crosses alveolar barriers and triggers systemic inflammation and asthma exacerbations thousands of miles away.
Mercury, emitted primarily from coal combustion in rapidly industrializing nations, remains in the atmosphere for about a year. It circles the globe, settles into oceans, bioaccumulates in fish, and poses a serious transboundary neurotoxic threat to developing fetuses worldwide.
And of course, greenhouse gases like carbon dioxide and methane drive global climate change, regardless of where they are emitted. A coal plant in one hemisphere directly contributes to the extreme weather events, droughts, and subsequent famines dispersed across all other national boundaries.
But it's not just environmental pollutants.
Hmm.
It is also economic transboundary risks. The butterfly effect of global economics is a profound health determinant. Let's unpack a fascinating historical example, the biofuel paradox.
Okay, let's get into this one.
Around 2007, established market economies like the European Union and the United States pushed aggressive policies to expand the use of biofuels, like ethanol, to meet national blending targets for their gasoline.
On the surface, if you are a policymaker in Washington or Brussels, this looks like a well-intentioned environmental intervention to reduce reliance on fossil fuels.
But what was the system impact? Because the global economy is deeply, inextricably integrated, the agricultural market reacted. A massive portion of global agricultural production switched from growing food crops for human consumption to growing biofuel feedstocks like corn and soy.
Because it was suddenly more profitable.
Exactly. The macroeconomic downstream outcome of that shift was a rapid, massive spike in the futures markets and the actual prices of global food staples, specifically grain.
So, a mother in Guatemala or a family in sub-Saharan Africa suddenly cannot afford maize.
Precisely. The ultimate health consequence was a sharp increase in food prices, which had devastating immediate consequences for undernutrition, stunting, and kwashiorkor in distant developing nations.
A policy drafted in a committee room in Brussels directly biologically impacted the nutritional status of a child in a completely different hemisphere.
So what does this all mean for us? It means that local disease surveillance and national health policies are no longer sufficient. Public health fundamentally requires international coordination.
It requires multilateral institutions like the World Health Organization to coordinate policies across borders.
It requires open-source data sharing and open government transparency initiatives. We need a global early warning radar because an economic shock, a novel virus, or an environmental pollutant in one hemisphere is a clinical public health crisis in another.
And the terrifying part is that sometimes those crises do not build slowly over decades. Sometimes they happen overnight. That is the fourth complicating feature: state changes.
Health determinants aren't always slow and steady. They feature abrupt, violent, tearing shifts in society or planetary systems.
The most glaring and destructive example is conflict. Wars between nation-states or internal civil wars are often camouflaged as moral, religious, or ethnic disputes. But fundamentally, if you look at the underlying determinants, they often originate from resource competition.
Wars fought over arable land, energy reserves, and water rights.
And the public health toll is immediate, absolute, and devastating. Conflict causes abrupt tears in the social fabric. You have scores of civilian trauma casualties, but beyond the kinetic violence, you have the massive and rapid unplanned displacement of populations under incredibly dangerous conditions.
You have the sudden, total depletion of essential resources like food, clean water, and sanitation infrastructure.
And we must highlight the severe physiological and mental health consequences that invariably accompany these abrupt changes. When people are forced into long-term refugee camps, even when a new stable state is supposedly achieved and the acute violence stops, the environment is often vastly inferior in its support of population health.
You see massive spikes in infectious disease outbreaks like cholera due to poor sanitation, but you also see the insidious effects of chronic allostatic load, the physiological wear and tear on the body from chronic stress. You see epidemic levels of PTSD, anxiety, and depression.
Because of this, preventing conflict isn't just politics. There is a powerful medical mandate here. Preventing state conflict is a core medical and public health duty.
In 1985, the Nobel Peace Prize was awarded to the international physicians for the prevention of nuclear war. This wasn't just a symbolic gesture. It validated the work of health professionals confronting the ultimate abrupt state change.
It elevated the role of health leaders in mitigating the flashpoints for conflict. Providing emergency surgical services in a combat zone or a refugee camp is essential, noble work, but it is never as effective as preventing the conditions that brought on the violence and displacement in the first place.
It's that upstream engineering again. But abrupt state changes aren't solely driven by human conflict. They are also driven by climate tipping points. A major psychological challenge we face is that climate change is often viewed as a slow-moving threat, something our grandchildren will have to deal with.
But slow-moving threats spawn sudden, immediate, catastrophic crises.
A perfect example is the 2005 European heat wave. You have a steady, gradual increase in global average surface temperatures. It seems slow. But that slow shift birthed an extreme weather event that transpired far more rapidly than the public health infrastructure could mitigate.
The physiological reality of that event was brutal. You had urban heat island effects, trapping the heat in cities that were never designed for those temperatures. No widespread air conditioning, poorly ventilated architecture.
And you had vulnerable populations, particularly the elderly, whose physiological thirst drive and thermoregulatory mechanisms are naturally blunted by age.
The social determinant of elderly individuals living alone, isolated from support networks, collided with this environmental extreme.
The result was over 40,000 excess deaths in a matter of weeks. Avoiding these large, irreversible negative health outcomes demands rigorous analysis and proactive leadership from the health sector long before the crisis hits.
So we've laid out the foundation, we've covered the classical framework, and we've explored the four complicating features: dynamism, multi-scale interactions, cross-boundary risks, and state changes.
Now, we are going to synthesize all this complexity. We are going to apply these frameworks to four specific real-world case studies to reinforce your pattern recognition.
Let's start with case number 1, China's migration and immunization gap.
This case is a brilliant illustration of the vital difference between simply having a public health intervention on paper and ensuring actual system access in reality. The setup is this. China made incredible, historic strides in closing the urban-rural gap in basic childhood immunizations, particularly for vaccines like hepatitis B.
They achieved this by making the vaccines free to all neonates and infants nationwide. From a purely policy standpoint, that is a massive victory. The biological intervention is available and funded.
But then you introduce the real-world complexity, massive rural to urban migration. We are talking about an internal demographic shift of over 260 million migrants moving at an unprecedented pace from the countryside to the industrializing cities.
Urbanization on a scale that took hundreds of years in Europe and North America happened in China over a few decades.
And what was a result of that highly dynamic demographic shift? The children of these migrant workers now have significantly lower immunization coverage than both the non-migrant urban children living right next to them and the non-migrant rural children they left behind.
The historical urban-rural gap was essentially replaced by a new migrant-non-migrant gap.
Let's play devil's advocate here. If the vaccine is free and available at the local urban clinic, why aren't the migrant parents just walking in and getting it for their kids? Is it an education issue?
It is a profound systemic issue. The vaccine is free, yes, but the dynamic movement of the population broke the delivery mechanism. Many of these families are moving frequently for temporary construction or factory work, making it nearly impossible to complete a multi-dose vaccine schedule like hepatitis B.
Furthermore, there are immense social determinants at play. Undocumented status in the new city, lack of local health insurance integration, dangerous and inflexible working hours that don't allow parents time off to visit a clinic, and the severe psychological stressors of being a marginalized migrant population.
You cannot just look at the biological intervention, the vial of vaccine. You have to understand the social and dynamic pathways of migration to figure out why that vaccine isn't getting into the child's arm.
That failure to see the whole system isn't just a geographic or demographic problem. It happens inside our clinics and hospitals too, specifically in how we divide up diseases. We treat chronic diseases and infectious diseases as if they live on different planets.
But biologically, they are colliding. That brings us to case number 2, the convergence of non-communicable diseases and infectious diseases.
Historically, public health has viewed these as distinct epidemiological transitions. Low-income countries deal with infectious diseases, and high-income countries deal with non-communicable diseases.
But today, low- and middle-income countries are facing a crushing dual burden simultaneously.
And there is a fascinating, deadly biological mechanism linking them. We usually think of NCDs and IDs as totally separate worlds. But type 2 diabetes, a chronic metabolic NCD, actually increases a person's direct biological susceptibility to severe communicable diseases, particularly tuberculosis and malaria.
Let's look at the mechanism. Chronic hyperglycemia, high blood sugar, impairs the function of the immune system. Specifically, it impairs macrophage phagocytosis.
The macrophages, which are the immune cells responsible for engulfing and destroying the tuberculosis mycobacterium, become sluggish and dysfunctional. The TB bacteria are able to survive and replicate inside the host much more easily.
In India, for example, diabetes is estimated to be responsible for more than 10% of the country's roughly 2 million annual TB cases. And as the prevalence of diabetes continues to surge due to those economic and nutritional shifts we discussed earlier, the proportion of TB cases attributable to it will rise in tandem.
So if you are a doctor in a rural clinic in India, your TB patient isn't just coughing because they were exposed to a bacterium. They're actively failing to fight it off because they have undiagnosed metabolic syndrome from an influx of ultra-processed foods.
And here's the profound public health failure that we must address. Historically, NCD programs like diabetes management clinics and ID programs like TB or HIV control initiatives operate in entirely different silos.
They have deep professional divides. They have separate funding streams. They are partitioned into different departments in academia, and they are managed by different bureaus within health ministries.
But to truly address the incidence of new TB cases, we actually have to aggressively treat the prevalence of diabetes in the population. We must target communities exposed to common risk factors across both categories. It demands completely dismantling those historic professional divisions.
Case 3 forces us to look at the intersection of economics and environmental toxicity. We are looking at extraction economies. This is a classic, tragic battle between rapid wealth generation and environmental health.
Developing nations often rely heavily on resource extraction, mining precious metals like gold, for instance, to fuel their economic growth.
It brings a rapid influx of capital. But the political and financial conditions that accompany this rapid wealth often lead to weak governance and high corruption. You get intense boom and bust economic cycles.
And during those frantic boom cycles, environmental regulations are completely ignored or actively suppressed. This leads to severe environmental and occupational risks.
Take artisanal and small-scale gold mining. To separate the gold from the ore, miners frequently use a mercury amalgamation process. They burn off the mercury, releasing highly toxic mercury vapor directly into their own lungs and into the local atmosphere and watersheds.
So you have miners presenting to local clinics with severe neurotoxicity, tremors, memory loss, neuromuscular changes because of an industrial process. So what is the solution? Is it building better neurology clinics in mining towns?
That is the 50th floor window washer approach. The real solution requires a return to public health's historical roots. We have to advocate for sustainable industrial practices before the hazard becomes a clinical risk.
We have to insist that the societal response extends beyond treating a poisoned miner with chelation therapy in a clinic. We have to go out into the environment, engage with the economic drivers of the mining industry, and implement safer, mercury-free extraction technologies to prevent the exposure in the first place. It is upstream engineering.
Finally, Case 4, the double-edged sword of urbanization and aging. This case beautifully illustrates the multi-scale, dynamic nature of health determinants, and it proves that no major societal shift is entirely good or entirely bad.
The setup is China's massive demographic shift. Declining fertility rates coupled with a rapidly rising life expectancy, which reached about 73 years back in 2005.
The complexity here is a fascinating demographic seesaw, because urban areas generally have much lower fertility rates and longer life expectancies due to better healthcare access. You would logically expect the cities to age incredibly rapidly.
But remember the 260 million migrants from Case 1, that massive influx of tens of millions of young, working-age people flowing into the cities acts as a demographic counterweight. It balances out the urban aging.
However, because all those young people left the countryside, the rural areas they left behind are now aging incredibly rapidly.
And this demographic seesaw has a profound, heartbreaking human cost. There are an estimated 20 million left-behind children in rural China. With the working-age adults migrating thousands of miles away to the cities for jobs, these children are left to be cared for by a single parent or, very often, by their aging grandparents.
The health outcomes of this fractured family structure are severe. Grandparents often lack the physical mobility or energy to constantly supervise young children. This has led to significantly higher rates of non-fetal and fatal childhood injuries, things like drownings, burns, and falls, due to reduced supervision.
Furthermore, the psychological toll of parental absence leads to profound, deleterious mental health effects, including high rates of anxiety, depression, and behavioral issues.
Simultaneously, at the other end of the age spectrum, the rural elderly are losing their traditional familial support networks just as they need them most.
This forces us to really balance the scales on urbanization. It is very easy to romanticize the countryside and demonize the city. Urbanization definitely concentrates risks.
You have the rapid transmission of TB and HIV in densely populated, impoverished slums. You have vector-borne diseases like dengue fever that thrive in poorly managed urban water resources and discarded tires.
You have obesogenic environments saturated with fast food and lacking green space for exercise. And you have the breakdown of social capital, which leads to chronic stress and violent crime. The urban poor disproportionately suffer all of these burdens.
But we have to remain objective. No major social changes without health benefits. Urbanization also concentrates massive benefits. It allows for economies of scale in building infrastructure. It provides much greater access to improved piped water and sanitation facilities.
It concentrates highly specialized healthcare infrastructure, hospitals, specialists, advanced diagnostics, and it often provides better, more diverse nutritional opportunities and educational access.
The mandate for public health professionals is not to try and stop urbanization. That is impossible. The mandate is to deeply analyze both the risks and the benefits, to develop zoning laws, housing policies, and infrastructure strategies that actively mitigate the ills of urban living while maximizing the incredible health opportunities it can provide.
It completely rewires how you look at causation. When you start seeing the world through this lens, you realize that the disease is just the final domino falling. So we want to leave you with a final provocative thought to mull over. If our health outcomes are deeply, fundamentally dictated by transboundary economics, long-term climate shifts, historical conflicts, and urban design, then the most powerful medical instrument in the 21st century might not be a stethoscope.
It might be a policy draft.
It might be a city zoning law. It might be an international trade agreement on agricultural subsidies. When you see your next patient, whatever their ailment, look past the immediate symptoms and ask yourself, what invisible upstream system placed them in your exam room today?
To solidify the frameworks we have just explored, let's test your memory and reasoning with 5 rapid single best answer style questions. I will read the question and the options.
Take a brief pause to lock in your answer, and then we will provide the correct response.
Question 1. According to the ecological framework of health determinants, which of the following is an example of an upstream distal determinant of health? A. Diet. B. Genetic predisposition. C. Globalization. D. Smoking.
Lock it in.
The answer is C. Globalization. While diet and smoking are proximal downstream behavioral factors that directly cause disease, globalization represents a distal, broad socio-environmental phenomena that shapes the environment, driving those downstream risk behaviors and exposures.
Ready for the next one?
Question 2. Which demographic phenomenon in China has resulted in lower childhood immunization coverage among a specific subpopulation despite national free vaccine policies? A. An aging urban population. B. Rapid rural to urban migration. C. Increased rural fertility rates. D. The convergence of NCDs and IDs.
Think about the delivery systems.
The answer is B. Rapid rural to urban migration. The mass dynamic movement of over 260 million migrants has compounded healthcare delivery and tracking, resulting in the children of migrants having lower immunization coverage than stable non-migrant populations, even when the biological intervention is free.
Let's look at economics for the next one.
Question 3. The 2007 spike in global grain prices, which severely increased undernutrition in developing countries, was primarily driven by which transboundary economic factor? A. The 2005 European heat wave. B. Biofuel energy policies in established market economies. C. Expanding extraction economies in sub-Saharan Africa. D. Decreased global agricultural yields due to Asian dust.
Yes, sir.
The answer is B. Biofuel energy policies in established market economies. The macroeconomic shift of global agricultural production toward biofuel feedstocks to meet EU and US blending targets rapidly increased the demand and prices of global food staples, directly impacting nutritional status in distant nations.
Moving to disease convergence.
Question 4. The increased risk of tuberculosis in India is significantly driven by the rising prevalence of which non-communicable disease, highlighting the biological convergence of NCDs and IDs? A. Chronic obstructive pulmonary disease. B. Cardiovascular disease. C. Obesity. D. Diabetes mellitus.
Lock it in.
The answer is D. Diabetes mellitus. Chronic hyperglycemia impairs immune function, specifically macrophage phagocytosis, increasing biological susceptibility to communicable diseases like TB, and accounting for a significant and growing proportion of TB cases in the country.
Last question.
Question 5. The concept that nutritional insults and stress during fetal and infant development can lead to profound susceptibility to chronic metabolic diseases later in adulthood best illustrates which complicating feature of health determinants? A. Dynamism and the life course perspective. B. Cross-boundary integration. C. Abrupt state changes. D. Multiscale interaction.
You think about the timescales.
The answer is A. Dynamism and the life course perspective. The Barker hypothesis and fetal programming highlight the complex temporal relationship and massive time lags between early life adaptations to exposures and long-term adulthood health outcomes. For a deeper consolidation of these critical frameworks, I highly advise you to revisit Section 2.1 of the Oxford Textbook of Global Public Health.
Here are the details of this episode.
Determinants of Health Overview. Byline. Beyond biology, the layered architecture of why populations thrive or suffer. Episode description. Health does not begin in hospitals. It begins in homes, schools, workplaces, neighborhoods, and policy chambers. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence: biological, behavioral, social, economic, environmental, and political. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. We examine classical models of health determinants, including ecological frameworks that depict health as the product of interacting systems rather than isolated exposures. Income, education, employment, housing, food security, environmental quality, social cohesion, and access to healthcare are not peripheral, they are central. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. The chapter emphasizes the distinction between proximal causes, such as smoking or diet, and upstream determinants, such as poverty, marketing systems, urban design, and governance structures. Effective public health strategy requires addressing root causes rather than only their downstream manifestations. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. Understanding determinants reframes responsibility. Illness is not solely the result of personal choices. It is shaped by structural context. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. This episode lays the conceptual groundwork for analyzing inequality, climate change, commercial influences, and access to care in subsequent chapters. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. Key takeaways. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. Health outcomes arise from multiple interacting determinants. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. Determinants operate at biological, behavioral, social, environmental, and political levels. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. Upstream structural factors often drive downstream risk behaviors. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. Socioeconomic conditions strongly predict morbidity and mortality. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. Health is shaped by policy decisions across sectors. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. Ecological models provide a systems-based understanding of causation. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. Addressing determinants requires intersectoral collaboration. In this foundational chapter of Section 2, we explore the concept of health determinants, the broad constellation of factors that shape population health outcomes. Moving beyond individual risk factors, this framework situates health within nested layers of influence. Prevention efforts are more sustainable when root causes are targeted.